Welcome to this overview of Pediatric Advanced Life Support. When doing a systematic approach to the initial assessment, evaluating the child's appearance, work of breathing, and circulation, if you find the child is unresponsive, immediately shout for help. If the child has abnormal breathing but a palpable pulse, begin providing rescue breaths. Properly position the child to maintain an open airway. Deliver 20 to 30 breaths per minute. That is roughly one breath every 2 to 3 seconds. Each breath should be given over 1 second and must result in visible chest rise. If breathing is abnormal and a pulse is not felt, immediately activate the emergency response system and begin CPR immediately. Focus on high-quality CPR. Push fast. Maintain a rate of 100 to 120 compressions per minute on a firm, flat surface. Push hard. Compress at least 1/3 of the app diameter of the chest. This is approximately 4 cm for infants, 5 cm for children, and at least 5 cm for adolescents. For infants, rescuers should compress the sternum with the heel of one hand or by using the 2-thumb encircling hands technique. For children, use either 1 or 2 hands to compress the chest, whichever technique allows the rescuer to achieve the desired compression depth. Minimize interruptions in chest compressions. Limit any pauses to less than 10 seconds, aiming for a chest compression fraction of at least 80%. Allow for complete chest recoil between compressions. This allows the heart to refill with blood and improves coronary perfusion. And crucially, avoid excessive ventilation. Compression to ventilation ratios in adults and adolescents is 30 to 2. For infants and children, use 30 to 2 for a single rescuer, but switch to 15 to 2 if 2 rescuers are present. If an advanced airway is placed, provide continuous compressions without pausing. Deliver 1 breath every 2 to 3 seconds. Remember to change the compressor every 2 minutes, or sooner if fatigued. Monitor EtCO2 and diastolic BP to evaluate effectiveness. If invasive monitoring is available, aim for a diastolic blood pressure of at least 25 mm of mercury in infants and 30 mm of mercury in older children. Attach an aid or defibrillator as soon as possible, using pediatric pads if available. If you identify a shockable rhythm, such as pulseless ventricular tachycardia or ventricular fibrillation, deliver an initial shock of 2 joules per kilogram. If the rhythm persists, increase the second shock to 4 joules per kilogram. Subsequent shocks should be at least 4 joules per kilogram, up to a maximum of 10 joules per kilogram. After the shock is delivered, resume CPR and do rhythm check after 2 minutes. For non-shockable rhythms, such as asystole or P, immediately resume CPR. Administer adrenaline as soon as possible for non-shockable rhythm. For shockable rhythms, give it after 2 attempts of defibrillation or sooner if rapid defibrillation is not possible. Repeat adrenaline every 3 to 5 minutes. The IV/IO dose is 0.01 mg per kilogram. If giving via endotracheal tube, use 10 times the IV dose. For refractory shockable rhythms, administer amiodarone at 5 mg per kilogram or lidocaine at 1 mg per kilogram. If torsades de pointes presents without a pulse, give magnesium 25 to 50 mg per kilogram, maximum of 2 g. Always search for reversible causes. Check your H's: hypovolemia, hypoxia, acidosis, hypoglycemia, and hypothermia. And check your T's: tension pneumothorax, tamponade, toxins, and thrombosis. Remember, resuscitation does not end with the return of spontaneous circulation. Excellent post-cardiac arrest care is critical for achieving the best patient outcomes. Thank you for watching. Please like, subscribe, and share for more critical care-related videos.